Hello, welcome to this week's HSJ Health Check Podcast. I'm Dave West, HSJ Deputy Editor, and each week on the podcast we bring together a group of HSJ's expert journalist team. Today I'm joined by Bureau Chief Ben Clover and by correspondents Nick Carding and Alison Moore. We are talking about the latest developments on coronavirus this week, and they're going to cover, firstly, the latest work on the extra risk from the virus to people with a BAME background. Secondly, recent developments on the testing and tracing for COVID programme and regime. And finally, NHS capacity for normal care as it seeks to navigate a COVID-infected world. Firstly, Alison Moore, we published a story by you yesterday evening about the latest developments and research that Public Health England had been asked to do on the relative risk to people from a Black, Asian, minority ethnic background from coronavirus, following substantial concern and already a background of evidence about extra risk there. Could you tell us about the latest developments?
Yes, well, the Public Health England report was issued yesterday afternoon, and I think it took a lot of people by surprise. It was rather dry. It was a statistical analysis. What it showed was obviously very shocking about the increased risk to people in the BAME group. However, there were things that were missing. We know that there'd been not a consultation process, but an engagement process where a large number of organisations and individuals had contacted PHE, giving their views, giving their lived experience and making some recommendations. That was missing from the report entirely, and there wasn't really much discussion of other vulnerable minorities. We've been promised something on people like travellers and gypsies. That was missing as well. It came to light yesterday afternoon that some of this had been included in what had been submitted to the Department of Health and Social Care and had been removed before it was published. And there was a certain amount of concern from some very senior people that this should have happened.
Do we have a feel of why this might have been?
Not quite certain. It's possible it may have been seen as quite heated, possibly even inflammatory at a time where obviously we're seeing a great deal of discord in America after the Floyd killing, and that this may not have been the right moment to publish this sort of thing. However, it does seem very surprising because the team that looked into this was led by Professor Kevin Fenton of Public Health England, and only 10 days ago he took part in a webinar where he referred to the three components of his study, which were going to be the statistical matter that came out yesterday, and in addition the results of the engagement, plus a look at the other vulnerable groups. And he implied that these were all going to be submitted at the same time to DHSC, and there was obviously an expectation there that would come out as a whole. So we're not quite certain why that's missing.
And we focused in on quite a lot on the bit that you described as I think wider engagement. So do you know any more about the kind of stuff that's in that report?
We know a little about that. The Muslim Council of Britain, for example, were quite vocal about what they saw as some of the issues, the sort of institutionalised racism that people of BAME origin face, and they made some very striking comments that would have been sent to PHE. I mean, they referred to structural racism and discrimination in the NHS, said that PHE should look into this in more detail and should look into specific measures to tackle the culture around this.
Can I just ask Alison, did the Department of Health say anything about why that bit was missing? I guess we put it to them. What was their official line on it?
We put this to both the Department of Health and PHE yesterday and again today, and they both say that nothing was removed. Now, we've heard from multiple sources that the draft that was knocking around last week definitely had this in. We've asked PHE and Department of Health again whether possibly this was intended as an additional document, and that had been held back, but they haven't answered us.
It seems like a sort of strange thing for them to pick to make an issue out of. If they just said, we'll publish this later, or we're going to publish it as an addendum in the next week, or you sort of feel like they're making a bit of a rod for their own backs by not being very open about it, because there may be a reasonable reason as to why it wasn't published, I guess, but it seems strange that they're not telling us why.
It does seem strange, and there may be a perfectly reasonable explanation for it. They just haven't given it to us. We have had it suggested to us, and obviously we can't confirm this, that some of it was removed at Mr. Hancock's office, not necessarily by Mr. Hancock, but within his office.
How many responses was this concerning, Alison? Did you already say? It was quite a number.
Yeah. It was meant to be between 1,000 and 1,500 from all sorts of different organisations. Obviously, some faith groups, some community groups, some other NHS-linked organisations.
Righto. And what we know so far is, did it also cover the specific roles that were most at risk, the types of jobs?
The report from PHE did yesterday, yes, and it highlighted a number of roles which had disproportionate risk. Top amongst those was actually security guards, then cab drivers and similar, but also nursing associates and auxiliaries.
Which may start to tell us something about the why, but potentially. And I think that was one of the things that there was, even before your story revealed that this work had been removed and wasn't being published alongside the rest. There was a lot of sort of disappointment and dissatisfaction among people who had a stake in this or were following the work. That the report which was published was very much a statistical, kind of dry statistical analysis rather than trying to get at the sort of whys and they seem to have, even in relation to the statistics, seem to have not carried out some analysis, as you said, which might have started to point to the why about are people doing different roles, are there different comorbidities in different ethnic groups and that sort of stuff. Is that?
A lot of people yesterday seemed to feel that this really didn't add very much to the debate. It told us things we already knew, which was basically that people of black and minority ethnic origin were dying in higher numbers than would be expected.
It reminds me a bit of some of these units were set up, governments of various types have set up these kind of units, and Theresa May's government most recently, because when she came out and said she was going to start tackling the burning injustices and talking about race and ethnicity, and sort of ask a statistical unit to say, right, we'll do the analysis and show, lay bare the issue here, and as if that will actually start solving the problem. Actually, a lot of this stuff, once you start to know about the numbers and facts that are out there, a lot of it actually is the numbers are there. I mean, more analysis can always inform things, but it's the danger of asking for and publishing only a statistical analysis is it just lays bare a whole bunch of facts which rather than starting to point towards action. And it seemed to me like perhaps a classic case where the government's received these 2 or 3 related pieces of work, and one of them, the statistical one which has been published, basically presents facts which don't sort of beg a whole load of, well, they do beg a load of questions, but they don't sort of they don't add a great deal of concern to the public debate because it's already out there. And then the more difficult bits, they've kind of said, well, these are in a too difficult box, and sort of because one thing they did say yesterday, I think the initial something that Matt Hancock said was, we're passing some of this work to the Equalities Minister, who I guess is in the Home Office, to sort of do some kind of next stage. And then subsequently, shortly after your story was published, I suspect not coincidentally, Professor Kevin Fenton, who was meant to be leading the work, kind of sort of then come out and kind of seemingly seeking to stress that the other work I've done, which hasn't been published, will at some point come out and will feed into this work with the Equalities Minister. But I mean, passing something over to an Equalities Minister in a different department, it feels like a long grasping of something, doesn't it? When the work's already been done, it feels like this was kind of too hot to handle for whatever reason, and we're now passing it to another department where it will take who knows how long. After they've had, can you remember when this work started? But they've had quite a long time to carry out this analysis in coronavirus sense.
A couple of months ago that it started.
And in a sense, it was already too late because we were in the midst of the peak of this disease.
Yes. And I think the decision to pass it to another department must have come fairly quickly, because, as I said 10 days ago, Kevin Fenton was talking of this all being published together at the end of May or early June. So possibly something's happened in the last 10 days which has changed minds.
Yeah. And just to add, I think I saw a line in your story, Alison, about some sort of activist to put out a tweet condemning the fact that this had been removed, and it was shared, I think, by Yvonne Coggill, the NHS England res leader. Is that correct? Or that seemed quite striking as well?
Yes, there's been quite a lot of Twitter traffic on this, and in fact the issue was raised with the Prime Minister at Prime Minister's Questions.
Did he engage with it substantively?
It may surprise you to know this, but no, he dodged that one.
Right.
Hopefully we'll start to get some answers soon. We should ask before we move on to the next topic, Alison, what's the NHS doing about this itself? Because and particularly for NHS staff, Ben, as you mentioned, one of the job groups particularly affected by extra mortality looks like it appears to be healthcare assistants. What's the NHS doing about trying to protect its staff who are BAME origin?
A fair amount. That there has been instruction from NHS England suggesting that every member of staff should be risk assessed to see if there's particular circumstances. I think one of the concerns has been that some staff who have become very ill and in some cases died from COVID had underlying comorbidities which they hadn't mentioned to their employer, and had the employer known, they might have considered redeployment to a less frontline role.
Okay, all right, thank you. Well, let's move on to our second topic we were going to talk about today, which is testing. And Nick Carding, you've been following the testing issue for us for a while now, through this sort of various stages of targets and calamities and
it's a lot to follow.
Absolutely, keeping you busy. And tell us what the latest. What have we seen this week?
So there's three separate sort of developments, I would say, that are worth highlighting. So the first one, end of last week, we revealed that the NHS had been given just 2 days to roll out thousands of these antibody tests, which are supposed to tell you if you've had COVID-19 in the past. It seemed odd when you look at it on surface, because sort of giving the NHS a very short space of time to roll out such a huge amount of tests seemed a bit strange, just to have that sort of short deadline. But then, of course, this happened 2 days before the deadline. So the deadline for the Boris Johnson's target for the UK to have a testing capacity of 200,000 tests. And around the time this message went out, the UK was currently providing about 160,000 tests, or had the capacity to provide 160,000 tests. And then the NHS was told you need to roll out about 40,000 or so antibody tests in the next few days. So there was a distinct whiff of this is being done purely to hit a target rather than serve any meaningful sort of purpose with antibody tests. And of course, it's worth remembering as well that we don't yet know, just because you've had COVID in the past, it might not mean that you're still immune to it. You might still be able to get COVID afterwards. So there is still uncertainty about how much meaningful info you can get from antibody tests. So that was one story which appeared to show yet again the sort of government's desperation to make sure they hit targets that they set, even if those targets don't necessarily make too much sense in themselves. Secondly, early this week, there is now an emerging row, I think it's fair to say, between Matt Hancock's department and the UK Statistics Authority. The latter has been raising concerns about the testing data, which is published every day by the Department of Health. He's the chair of the authority, Sir David Norgrove, I think his name is. He's written to say that he thinks that Mr. Hancock's department isn't really being very transparent with the data. They're saying that the data is, quote, neither complete nor comprehensible, and sort of calling for immediate improvements there. Matt Hancock had responded to his sort of initial letter last week, pledging a bit more transparency and saying they would publish some methodology and sort of try and provide it a bit more clearly, but clearly that wasn't enough to sort of placate this particular watchdog. So it'll be interesting to see what they what Department of Health does after this sort of rather stinging letter which they received.
Who are these, as a side note, who are these sort of statistical heroes who have popped up to
so the UKSA is responsible for I think they're sort of responsible for, as they say, maintain the good practice for statistics across the country. In theory, what they do is they look after the sort of monitor the Office for National Statistics. There's something called the Office for Responsible Statistic Distribution. It's a non-ministerial agency of the government which is there to kind of regulate / help departments with their statistics. To be fair to the DH, they made the point that, you know, this whole testing saga and setting up the testing capacity has been done at quite extraordinary pace, which it has, to be fair.
It has, although now well over 3 months. You know, even if you 3 months, even if you you know, give them a sort of reasonably fair hearing as to when they should have started it, I suppose.
Yeah, absolutely. You could argue that they started from a woefully bad place, but clearly, I'm sure it's complicated to present the data in a sort of clear way when you're dealing with lots of different companies that are helping you, and they all run their own separate data systems. We've reported previously about some of the problems with data flows, but then equally, it was interesting to see that shortly after Mr. Hancock had replied to the authority, they did publish a bit more data. So they published the sort of testing capacity available, and you sort of wonder and also they published methodology, and you wonder why they just couldn't have published that straight away, because clearly that was information they must have had, you know, in the last 2 months, but they just haven't chosen to publish for whatever reason. But it doesn't really make any sense why they couldn't just publish that along with what else they were publishing. So we'll see what happens. The authority, the UKSA, wants them to publish regional breakdowns. It also wants them to make clear exactly why tests that are posted out to people are counted as part of the overall tests processed number, because that's very, very controversial, and we've never had a real answer as to why they should be counted in that way.
That's something one of the things HSJ revealed on the eve of the first target deadline, the end of April. Was kind of very conveniently sort of our numbers started popping up just at that time to meet the first 100,000 target, didn't they? Before a whole load of numbers for the antibody test just popping up at the end of May to meet the 200k capacity target.
That's right. Yeah. So yeah, there's no clear explanation as to why those tests should be counted. Those tests that are posted out, and Sir David in his most recent letter again made the point that, you know, you're also not telling us how many of these posted tests are actually returned and returned with samples that can be used. So again, that's another set of data that is missing so far. But then encouragingly, today, just to come on to the last sort of testing strand, Boris Johnson said that they are now targeting to turn around all tests within 24 hours, and that's hoped to be in place by the end of June. So he mentioned last week that they were going to try and turn around all tests by in 24 hours, but it didn't say by when. So today he said it's going to be the end of June.
So you can now hibernate until the 28th of June when you come out and find out what tricks they're up to at that point.
Possibly, yes. Although I think it's interesting, and the reason I say it was encouraging is because I think the turning around tests quickly is clearly really, really important, and it helps both the NHS and wider public health and councils sort of work with the contact tracing and work out how the infection's spreading. That is arguably, I'd say, far more important than having a number of tests available every day, as long as you've got enough capacity to deliver what you want. And we know that we've got that. So this target feels more legitimate than just setting a number, aka 100,000 by the end of April or 200,000 by the end of May. This target feels like it's got more clinical purpose and value. And I just wonder if that might be a result of some more involvement now from Dido Harding and Sarah Jane Marsh, with those two having come into the sort of leading the test and trace program quite recently, and they have said previously that that's what they wanted to focus on. So I just wonder if that might be their influence starting to filter through, which I think is a welcome change.
They've suggested that they want to bring some kind of coherent strategy to the way this is working, but I mean, just looking from the outside, it still looks like a kind of a broth with a lot of sort of chefs standing directly around it, kind of prodding it around, doesn't it?
Definitely, it's still very messy, and if you look at the testing website at the moment where they set out all this data, the amount of sort of different explanations and different methodology, and the need to change numbers from previously which have been erroneously reported, there's a lot of that, and you've got various private companies involved in running different parts of the testing program, like I said earlier, sort of contributing to a bit of a melting pot of people doing different things, but all for the same purpose. So it is still a very messy layout. I suppose the DH would say it had to be that way to get it scaled up so quickly, but hopefully it can be a bit more.
Ministers still involved in the operational kind of thing, and still involved closely in the operations and that sort of stuff. On the antibodies thing, I mean, I just wanted to return to the sort of substance of that, because as you said, so the NHS was asked to start carrying out about 40,000 antibody tests very quickly. We don't, we assume it's linked to the target, though we don't quite know. Well, it was definitely linked to the target at the end of May, but we don't quite know whether the government ordered it or whether the NHS sort of decided it had to be done or what. But we do. As you said, the letters. The interesting question of, well, why? Because obviously it's quite nice to know whether you have had coronavirus. I'd quite like to know. But what's the actual point of doing something? I can't see any point in doing it that quickly. But what's the actual point in doing for rolling out a mass program at this stage at all? And the letters, because the letters were very clear, and starting with NHS staff obviously begs the question and makes a lot of people think about, well, are you trying to? Is it about immunity? Are you saying therefore that some staff are immune? And therefore they can potentially work in more risky situations, work in coronavirus wards and so on. But the letters are absolutely clear that is not the case, because we haven't proven that people are immune. Now, I think there's I think there could be other reasons for it other than that, and there's ones that have been put forward is generally vaguely it's about research. Well, what research and what kind of research trial, what kind of robust research involves like rushly carrying out tests on anyone who's willing over in NHS staff groups across a period of a couple of days. But if it is research, well, are they trying to research about immunity? And if so, what kind of study is being carried out? How long will it take to report and things? If it's not about immunity, so if it's not about research, then there were some interesting responses from people who seem to be quite well informed on the HSJ website, and I've seen some other comments from people who are medically trained or scientifically trained about. Actually, there is it is considered pretty likely that you have at least some immunity for some period of time. And people saying that actually it is useful to know this information, and very much suggesting that they will kind of try and act on it in terms of how they plan staffing in the NHS. So part of me, suspects that actually it is planning to be used in that way, if not immediately, then then people are hoping that they do very quickly get an answer to this, some sort of answer to this immunity question, and then they can start to use the data to do something about it.
Yeah, that's very likely, I think. I think what really bugged some of the pathologists that I spoke to when we were just trying to get some feedback about what they were being asked to do was that because it was being rushed out, they were basically telling people just test anyone. And the point that a few heads of pathology made to me was that, if we could identify the right staff to take this test first, for example, if we sort of, got everyone who had thought they had COVID, if they had symptoms, they don't know if it was COVID or something else, but they had symptoms, there's more you can do with that data rather than just randomly testing people.
In a sense, for study-wise, the problem is it's not random, is it? Because the people who are going to really want to do it are the people who think they have had it probably or might have had it, whereas if you're carrying out a study, you need to select them on yourself, you need to select them randomly and have control groups and things like that to say, because it might be interesting, well, I'm sure it will be interesting to look at the proportion of staff who've had it in different hospitals or care settings to see whether there's something about spread, and whether there's been a lot of suspicion about hospitals where there's in-hospital spread, and they're a big centre of where the infection's coming from now. So which hospitals appear to have been much doing that, and was it because they're bad on infection control and so on?
Absolutely, but that's the point that they were making. They were, because they were basically being told to just test anyone who was around, and not really take into account what sort of the importance was of testing that particular person. It was just let's rush out and test them all now, rather than doing it properly. And that again just harks back to the desire to hit the target rather than to get any kind of meaningful data from it, per se.
Ben or Alison, I think you've both been looking a little bit about this question of spread within hospitals of the virus, and that being quite an important, being considered an important factor now. Is that? Have you heard anything about that?
There's been some reporting on it, showing it's one of the more significant drivers of infection. I've spoken to people in hospitals who've said, if this does turn out to be an illness that's going to be with us for a long time, then it might be a sort of a new performance measure for trusts in like a year and a half's time or 2 years' time, is like number of hospital-acquired COVID cases. There was some reporting somewhere else about the average amounts of how much infection was picked up in hospital, and put it at 20%, but other hospital leaders said the average is more like 5 to 7%, but there was one place in particular that its infection control was so bad that it dragged the national average up to 20, which would be pretty startling if it was true. And you'd think people would want to know where that was, if only so as other people could very much not make whatever mistake they were making on infection control.
Maybe that was Western Hospital, which was closed obviously 2 weeks ago because of the high number of COVID cases there.
That would make sense, wouldn't it? Yeah. That's Dido's local hospital. So that's obviously a factor, and also the number of hospital-acquired infections of patients and of staff is one of the big factors around the thing I was going to talk about the overall capacity of the system, the kind of capacity that the hospital system's going to have in the medium term. That's something I've been writing about over the past week or so. It's just from talking to planners about how hospitals gear back up to delivering elective procedures again. And lots of this is very consequential stuff around cancers, but it's also like the great mass of procedures that are a lot of people's experience of the NHS, kind of like hip and knee replacements, that kind of thing. All of that's been suspended for about 8 weeks now. And I've been having some conversations with people about exactly what sort of level we might be able to return to, because there's obviously concerns that if you go in for an operation, and then you catch COVID-19 and die, then that's obviously suboptimal. So how do we avoid that? So there's a load of different questions about how you restart it. Like hospital leaders have said, it's much more complicated to restart providing these services than it was to stop them in the first place. But anyway, the long and short of it from my conversations with people so far is that the estimates of how much work they'll be able to do in the new world compared to their run rates beforehand could be anywhere between like 40% of what they used to do all the way up to 80 at the more optimistic end. And that's talking to clinicians and managers who've described kind of like how you would set up cold sites where people just have planned procedures and where you don't do anything else, and then you test people before they come in to make sure they're not bringing it in with them. I mean, you'd also have to test staff every day, I guess. So there's all kinds of things that will make that complicated. But then that's having knock-on effects already. So the April elective waiting times data and the cancer data isn't out yet, which is the month we would have seen the most disruption. But the March one is, and you can see on electives. It looks like the number of year-plus waiters on the elective wait list is people who've waited more than a year for their treatment and who are still waiting has gone from like about 3,000 to about like 33,000. The data indicates they might have managed to treat a couple of people, but I think it's unlikely. So yeah, there's lots of concern about how you prioritise and like a number of kind of knock-on effects of that. I was speaking to some clinicians who say that the NHS is just going to have to stop providing some procedures, things that were kind of have been on the they've gone by many names over the years as commissioners try and stop providers from carrying out these procedures, but things like they're called like procedures of low clinical value, and saying there just will not be the theatre time probably.
Possibly the broader end of that list, because a lot of those there's not a great deal of it goes on anyway, is there? So list plus the sort of lower value end of stuff that actually has generally not been rationed much so far.
Yeah, kind of things that are sort of kind of bread and butter parts of the NHS's offer, like a hip or knee replacement or something like that, where you go, well, look, you might have to soldier on for another 2 years without this before we can get around to it. But anyway, I was reporting earlier this week the London's looking to extend the block booking of private hospitals in the capital, kind of specifically to try and catch up with this kind of ever-growing mountain of work. And there's a number of implications for that. I mean, because broadly, well, in fact, all private hospitals in London don't have an A&E. They have been fenced off. Some of it's already been used for cancer stuff, but it's just kind of remarkable that for possibly the first time in its history, you could end up effectively nationalising Harley Street and other sites for quite some time. I mean, 2 months is what the consensus seemed to be at the moment, but a lot of the planners I spoke to said, yeah, we'd really want to extend this to the end of the financial year. Next March, or even like a full calendar year. There's also worth pointing out that the managers I spoke to said it'll feel quite different. So it'll be staff who are used to doing most of their work in an NHS trust and maybe doing some private work in a private hospital, now doing all of their NHS work in the private facilities, which are going to be designated COVID-free and hopefully enforced COVID-free. Obviously, this has wound up quite a lot of senior medics who point out that it's they're going to drive out to Essex to do their private work there. I mean, although actually,
what you mean as opposed to London?
Yeah. I mean, like London, Lang and Buisson put it in 2018 at something like the central London. The turnover of the central London private facilities was about 1.6 billion a year. So it is a major hub for international medical tourism and just general private work, domestic private work. But yeah, there'll be knock-on effects
Do you you were talking about hot and cold sites in relation to this? Do you is there? I know that hospitals are dividing up wards and floors and units and things to create hopefully COVID-free facilities. But are there a lot of NHS hospitals being designated as COVID-free cold sites?
There's in London, which is sort of led on this, and as contacts have pointed out, kind of although the scheme, the extension is happening in London, first of all, there's no reason why those same issues aren't going to be faced everywhere else. About how do you separate?
They say they have to separate. But the people I've talked to outside London broadly say the options for having COVID-free sites are less, substantially less outside London or maybe the West Midlands and Greater Manchester, Liverpool built up areas where there's enough sites to do that, because they don't feel they can be, classic sort of reconfiguration issues. They don't feel that they could split hot and cold and expect to send their patients, however, half an hour or however long up the road to a different site. And they'd rather go, and presumably it would be potentially more contentious as well, because you've got you're designating a whole a whole town or city's hospital or county's hospital as COVID or not. Gets a bit more controversial.
Oh yeah, no, that's why they said they would want to use that private. They would assume the same demand for private facilities would be out in the rest of the country as well.
Certainly beginning to see that a little in the southeast, with a number of the trusts here looking to continue to make use of private facilities, particularly around things like cancer, where obviously you really don't want a cancer patient mixing with someone with COVID. And I think some trusts which are double-sided will look to make one site a COVID-free environment where, for example, they can carry out elective work as far as that is possible. And I think the big question for many of them is how much of their elective work they will be able to restart with that sort of approach.
Yeah, that's the kind of calculation planners are making all over the country.
Yes.
And I think you've written, Ben, that you would think it would end up somewhere between 50% of normal operating capacity to around maybe 50, 60, 70, 80, best case scenario, 80% of normal.
Yes, so London's piloting a scheme where they kind of bullishly think they can get it to 80%. Some views I've had from elsewhere in the centre suggest it's probably more likely 50%.
Because that involves this is going to have private in London and
yes, like lots and lots of it. But yeah, there's also going to have to be questions about how you pay the private sector for this work, kind of because the tariffs that are used for the sort of the high volume procedures, the ones that quite commonly got put out to private providers to deliver for an NHS tariff anyway, they're all designed for a world where those procedures were a lot less expensive to do, and where you didn't have all these measures that you had to put in place beforehand.
Yeah.
So
and
that's.
And there's since you raised the question earlier about prioritisation. Is there elective activity? Are there types of operations that the NHS is basically going to stop doing to all intents and purposes? Which is should become a political question, though. I guess as forever, the politicians will try to avoid answering it directly. But then the political, there's a question up there for whether it's or the Simon Stevens or the politicians about if the NHS can only operate at the NHS on as it currently is can only operate about 60, 70, 80% capacity, then do you want the NHS to just carry on doing that for the same cost, or do you want it to expand its capacity as far as it can, as if it can if it can build facilities and find staff to do it? Do you want it to expand that at the cost of whatever, substantial billions, I would expect, to run its emergency and elective care at the same rate as before? To get the same, you'll need to spend more money and find more staff and more buildings.
Yeah, no, like pretty significant capital asks have gone in from the ICSs in lots of cases, I'm told, for exactly that, for having separate facilities where you can sort of blast through quite a lot of the lists. But yeah, I mean that's probably a saving long term compared with continuing to use the independent sector, which might want to get back to doing their own work after a while. A question of how long you could actually use that stuff without making those providers unviable.
Okay. All right. I think we'll be talking about that issue for some time to come, and the consequences of it. Thank you very much, Alison, Ben, and Nick, and thank you for tuning in to listen. Please subscribe via podcast app. Visit hsj.co.uk to read more of our news and analysis. If you want to give us any feedback or ask us to cover anything in particular, you can contact us on Twitter at HSJ News or find my email address out there. Please spread the word and speak to you next week.